Lunch hour. So thank you, Ashley Williams, for being here today to present at our HSPRI rounds. Um, for those online who haven't met Ashley, Ashley is an occupational therapist by professional background and health services researcher focused on improving health and well-being for military veterans and public safety personnel. She was here at Queen's working with Catherine Donnelly and Heidi Cram for her doctoral research and now a postdoctoral fellow at the University of Regina. And so I'm excited to reconnect with Ashley and hear about her work. So thanks, Ashley. I'll pass it over to you.
Great. Thank you so much, Jordan. I'm really happy to be here at HSPRI Rounds. I think this might be my first or second HSPRI Rounds. So I'm going to go ahead and share my slides. Hopefully it'll do what I wanted to this time. Oh, maybe not.
Oh, still seeing the,
There we go. It should be okay now.
you got it.
Perfect.
Great. All right. So welcome, everybody, and thank you so much for being here. And for your interest in this work. So I'll be speaking today. I'll kind of be painting a bigger picture than just this one study that I'm here to talk about today, but really I'll be focusing on the transition from military to civilian healthcare with a focus on primary care. And for this talk, we're going to emphasize what that looks like before folks transition out of the Canadian Armed Forces. So in the months, potentially years leading up to release, what does this transition actually look like? So before I dive in, I want to give some acknowledgements for funding that I received for this work for Wounded Warriors Canada and SIMVR in the form of a doctoral scholarship, and also from the Ontario Ministry of Training, Colleges and Universities, also in the form of a scholarship. And I also wanted to take some time to thank Dr. Brent Wolfram, who was a huge support through this work and a wealth of knowledge. And, he was just a wonderful support in getting this work done. So I know many of you in the room may know Dr. Brent Wolfram. And if you do, pass along my thanks if you see him. And also, of course, I want to thank the research participants because we can't do any of this without them, and it's all for them. So, uh, you know, the greatest degree of appreciation is certainly to the participants who shared their stories and took the time to share their stories. So just to give you a sense of where we're heading today, we're going to start off, I'm going to set the stage, kind of tell you a little bit about me, how I got into this work, why it's important, and why I chose to focus my doctoral work on this. We're going to focus in on the pre-release experience sort of in particular and in the most depth. And then I'll tell you the rest of the story, what happens after people actually release. Then I want to kind of put all this in context, particularly present context, because the primary care crisis in Canada has only gotten worse since I started this work. So I want to kind of contextualize what that looks like. And then hopefully, if I don't talk too much, we'll have some time for questions and discussion. So just to tell you a little bit about me, so Jordan already gave you a little bit of my professional background. You may have picked up on my accent. I am from Newfoundland. Been in Ontario now for 13 years, I think. Um, and actually, the reason I came to Queens is because my brother is in the Air Force and he happened to be posted at Trenton at the time. And so Queens is like an hour away, so seemed like a great fit. And the year that I started my doctoral work, my brother actually released from the Reg Force. And so this is sort of what sparked my interest in military to civilian transition in particular. And, I was already working in primary care as an occupational therapist and sort of aware of how important that element of the healthcare system is for all of us. And so that's kind of where my interest for this came in. But, so I've got some kind of professional and personal connections to this work. And I think just for me personally, It's always been an important value of mine that we should serve those who serve us and make sure that people who, make the sacrifices that are necessary to serve our country, making sure that they are taken care of when they're finished with doing that work. If one ever finishes doing that work. So military to civilian transition, just in terms of broad strokes, is really the process of leaving military service and transitioning to civilian life. Of course, anyone who's actually been through it can tell you that it's a lot more complex than that sounds. Each year, about 5,000 regular force members leave service. When you include reserve force, that number goes up to about 9,000. Most releases are voluntary or for medical reasons, although the number of medical releases is going up. And there's also been a trend in increasing difficult transitions. So every 3 years, when we do the veteran well-being survey, or the life after service survey, as they were called in the past, um, we noticed every time they did that survey, the proportion of veterans reporting a difficult transition seemed to be increasing, which is a problem. So it's really a very complex phenomenon that has major implications for well-being. And one of the reasons for that is because the military is really a very unique career path. And this quote on the top here from Delaire and Wells really kind of exemplifies this point. When you join the military, you go through a cultural indoctrination. You are in a military community, you are looked after. It is unique. So, one of the things that really impacts military to civilian transition that we already know is the presence of health issues. Now, you can have health issues without necessarily having a medical release, but these two types of releases, we do see some differences in terms of health outcomes, of course, and also difficulty associated with the transition. So, everyone who leaves service is going to be going through a cultural shift, moving out of the CAF and into the civilian world. You got to find a new job if you're going to be working. You got to find health care. You got to figure out where you're going to be moving if you're going to be moving. There's a lot involved in the transition, even when you don't have health issues. And then, of course, when you add health issues on top of that, that makes the process that much harder. So, what does the health profile of veterans look like, in particular relative to the general population? So, we do know that veterans do report some health issues in greater proportions than the general population. So there's a few here on the screen you'll see. So depression, anxiety, PTSD, chronic pain, hearing issues is another one, back pain in particular is another one. So all of these are reported in greater proportions in the veteran population relative to the civilian population. And about 32% of veterans have comorbid mental health and physical health conditions together. And when you have a medical release, you're more likely to have a difficult adjustment and difficulty with health related activities. So, for all of these reasons, the health service transition is really important when we think about transitioning to civilian life. Another reason, in addition to the health concerns, why this is important is because the health system that veterans are transitioning out of is quite different from the one that we experience as civilians. So it's quite integrated and specialized, very interdisciplinary. We do see more of that in the civilian system, but it's, par for the course in the Canadian Forces health system. And military members, while they're in service, always have access to a primary care provider. That person may not necessarily be a military member, um, but they do always have access to some form of primary care, even if it's sick parade like walk-in clinics. When you get to the civilian side, of course, it's really your responsibility to find primary care, and not everybody has it, of course. We're seeing that in the news all the time. So it is quite a different system. You don't always get that interdisciplinary team, particularly in primary care. Getting access to begin with can be really difficult. And then if you don't have primary care, that makes it a little bit harder to then access other parts of the health system. So veterans really have unique health needs that have to be met in the civilian primary care system because, of course, after they leave service, they no longer have access to the Canadian Forces Health Services. We also know that there's a lack of evidence to inform practice and policy in the Canadian context, and a lack of understanding about what the healthcare piece of this transition actually looks like for people. So, a significant percentage of services are provided by family physicians in primary care. However, it is unclear if the civilian healthcare system's current capacity and existing means of professional development are prepared to meet this challenge. So, this came from some work that Alison Mahar and colleagues did in 2017. So, calling out this sort of gap that we see. So, as a result of noticing that gap, I had two questions that I wanted to answer. So, one was, how do CAF members and veterans experience the health service transition in the context of military to civilian transition? And what does interprofessional primary care actually look like once veterans are attached on the other side? So, we'll be focusing more on question one, but I will touch on question two. So, I'm going to give you a methodological overview. So, think of this as the trees in the forest. I'm gonna zero in on a few trees as we go through, and then I'm gonna sort of broaden things out and look at the forest. So this is sort of an overview of the project, of my whole PhD project. So I used a multiple methods design, primarily using phenomenology and case study methods to answer these two questions. And of course, I'm looking at a transition, so we really need to understand what the transition looks like over time, right? Transition is a temporal phenomenon, it unfolds over time. So we want to know, what does it look like before people release? What does it look like in the midst of transition? So in the time frame up to 3 years is what we looked at after release. And then what does it look like once folks are actually attached to primary care on the other side? What does that care actually look like? So we conducted 3 studies, each focusing on one area. And today we're going to be zeroing in mostly on that first study. So this is the pre-release. We want to know, what are CAF members experiencing as they approach their impending release? Is this something that they're thinking about? Are they worried about it? What does it look like? And again, using a qualitative phenomenology design, and we conducted in-depth interviews and used Mustakis's method for data analysis. The second study, again, focused on the midst of transition. Methods are very similar. We're just now looking at a different piece of the transition. And then I used a case study for that last piece to look at, what does care actually look like. So I wanted to be able to conduct interviews with healthcare providers and veterans, be able to look at some charts, and also look at some policy related documents as they relate to veterans, and kind of get a picture of what that looks like. So let's dive into that first study. So this study was actually, we used previously collected data from a longitudinal qualitative study on military to civilian transition, which was the first of its kind, the first longitudinal study on military to civilian transition that we know of in the world. So the aim of this study was really much broader than health services specifically. So it was really about understanding the mental health and well-being overall of veterans as they transition. And we took that data and we sort of did a deep dive on the health and health service components of that data. So even though this wasn't the primary focus, it was something that we asked folks about and that came up in those interviews. So at the time, I wasn't really conceptualizing this as a secondary qualitative study because the aim here was sort of embedded within the overall aim of the longitudinal study. But now, after some time, I think what we did definitely was reminiscent of a secondary data analysis, and I'll talk a little bit more about that when I talk about limitations. But just to sort of set the stage and give you a sense of where this data came from. So if there's any qualitative researchers in the room, this is going to be your time to shine. So this is the phenomenological data analysis process that we went through. So phase one, phenomenological reduction, that's gonna, if you read the steps there, again, anyone who's familiar with qualitative analysis is gonna recognize those first 5 steps. Looks a lot like a thematic analysis. And then the second piece, the imaginative variation, this is really where we bring in the how of the experience. So we're not just looking at what happened, but also how people experienced it. What did it feel like? What drove the experiences? What were the implications? And sort of putting both of those together, so the what happened and the how it happened, merging them together to sort of get a better understanding of the essence of the lived experience. Happy to answer questions on this if anyone has any. So, what did we find? So, the total number of people interviewed in the longitudinal study was 80, and we used 69 of those interviews because in the remaining 11 there was no data about healthcare transition. So, breakdown of the sample here. Most people were most people were commissioned ranks, which is unusual. Usually you get a lot of non-commissioned ranks. Um, and for service element, pretty much looked like proportionately anyway, what you'd expect. So mostly Army, followed by Air Force, and then Navy. And then release type, mostly medical, and then fewer voluntary. So there were some differences in what the overall veteran demographic profile looks like in our sample versus uh, what it looks like in the whole population. So, what did we find? So, the first theme is on the precipice, anticipating change. So, this is where folks were there was a lot of trepidation for some people, especially if there were a lot of health issues already that folks knew they were going to need follow up on after they left service. And so there's, some worry and concern and uncertainty around how am I going to make this work? What's available? What are the options? What's this going to look like in my area? Um, so a lot of sort of concern about the uncertainty of it all. And then that theme two, making the leap, support and preparation. So this is sort of where people are, imagining themselves a few months in the future or a few weeks in the future, wondering what's going to be available to help me get through this. And what we found for a lot of people was that there wasn't a lot of formal support directly targeted at the health service transition. It wasn't that people were saying there was no support at all. It was more that there was not enough for this particular piece of the transition. And then theme three, wouldn't it be nice? So this is where folks were making recommendations around, if this had been different, my experience would have been better, I suspect. So just to give you a few exemplar quotes here. So for that first theme, uh, one participant noted, I cannot emphasize strong enough, I guess, the ambiguity I'm facing with healthcare. It's definitely not helpful. And then that second theme around support and preparation, all of a sudden, it feels like it's all gone. The doctor that you've had for 25 years, she's gone. All of a sudden, it's like, okay, you're on your own to find everything. So there was really this sense of being sort of left to your own devices or sent out to pasture. And then for that third theme, medical follow-up piece would be useful. To continue to access those services, at least on an interim basis for a while after releasing, would be fabulous. So, this is a veteran who was talking about being able to continue with the Canadian Forces Health Services after release, at least for the interim while they're setting up health services on the other side. There we go. So, the key implications here for this first study looking at pre-release was again that uncertainty and how much that impacted folks as they were preparing for release. Um, and then also the lack of support in preparing for that particular part of the transition. And this QR code here is a link to the published paper if anybody's interested in doing a bit of a deeper dive into this. And I'm also happy to send the link to anybody if the QR code's not working. And so I wanted to speak to this again for anybody in the room who's a qualitative researcher, or if you're just interested in methods. So this study has all the limitations that you would expect for a qualitative study. So, the population doesn't exactly, it's not a representative sample as, for the most part, qualitative research rarely is. Folks were self-selecting into the study because they wanted to share their story. Um, and we also had those issues around, medical release experiences being overrepresented. Same thing with with sex actually. So we had a lot more females than we did males, which is unusual. It's not that it's unusual. It's just that we had a much bigger proportion of females in our sample than you see in the veteran population. So again, female experiences may be overrepresented. But the piece that's really interesting here is this idea of a secondary analysis on qualitative data. So the biggest issue that came up when we were trying to figure out whether this would work or not is this idea of methodological congruence. Are the two purposes and the methods you would need to address those purposes similar enough that you can trust that the data you're using will answer the question you're asking. And so we did feel like there was a fair amount of methodological congruence in there because the original study did include the the healthcare and healthcare access piece for some folks, and overall the uh, paradigms that the research was rooted in were still the same. However, um, normally when you do qualitative work, you're looking for richness and depth in your data. And because this was not the primary reason this particular data was collected, we didn't get the same richness, the same thick description that we would get if the entire interview had been focused only on the healthcare transition. So we don't have the same level of nuance and richness that I would like to see from a qualitative study. So that's sort of a limitation around that sort of secondary analysis piece, and something to keep in mind for sure for anyone in the room who wants to do qualitative work and is looking at a secondary analysis. This is might be a limitation that you run into depending on the question you have, um, and how closely the data you're looking at aligns with it. So now, oh, sorry, I just got a funny sound in my headphones. Hopefully everybody can still hear me. Um, so now we've done this deep dive into what things look like before we release. So now I'm going to tell you the rest of the story, a little bit more briefly, and then we'll sort of get into the context stuff. So, what did this look like in the midst of transition? So we interviewed 16 veterans specifically about the healthcare transition in the 3 years after they released. Similar analysis process, but the data was a lot more rich. So, what did we find here? So, the first theme was this idea of leaving the mothership. And this idea of leaving the mothership was actually, and like being lost in space and that kind of thing, was actually something that was raised by a number of participants. This analogy to being lost in space, which I think is a pretty important point, that that many people are raising the same analogy. So this idea of acclimating to a new system. So again, you're moving into a very different health system and a different culture. Um, and so there's a lot of stuff to figure out. And the figuring out wasn't really the big issue. Most of the things, like figuring out how to get a prescription filled, that kind of stuff, it was foreign initially, but then you get the hang of it. Um, However, this idea of kind of being left to your own devices and not really knowing what you're going into, a lot of people experience, especially if they didn't have a whole lot of exposure to this civilian system. A lot of folks experience some shock, particularly at how hard it is to find primary care once you leave service. And this second theme was this idea of being stuck in outer space. So, this gap between military and civilian primary care. So, because folks are losing access to to the Canadian Forces Health Services, essentially overnight after they release, um, that really raises the potential for a gap in continuity of access. So folks leave service, if they don't already have a primary care provider set up, they don't have anything. And so you're reliant on things like walk-in clinics, urgent care, emergency. And when you've got a lot of health issues that need regular follow-up and you can only raise one issue per appointment, it becomes a very onerous task to take care of your health. Um, you know, it becomes a full-time job and is described by a lot of folks as nightmarish, especially when you're used to being able to go to sick parade, in the morning when you need to. Um, and then that third theme, walk you across the bridge. This is around, how do we bridge that gap? How do we make this process easier so that folks are not sent out to pasture or don't feel like they've been sent out to pasture? So this is an exemplar quote from one veteran who was in the midst of a gap. So he had left service, hadn't found primary care yet, and was one of those folks who hadn't had a lot of exposure to the civilian system and was fairly surprised by how difficult it was to get access. So he says, I'm in a nervous position right now. I don't feel supported or taken care of because I don't even have that point of contact. I wish I did. And so the key points here is that the shift between systems could often be surprising and certainly entail the learning curve. Gaps in access could present a significant challenge, particularly if you already have health issues that need regular follow up, regardless of whether it's a medical release or not. Um, and there's also a sense that there wasn't a whole lot of formal support, again, for this particular piece of the transition. And for some folks, that left them with a sense of abandonment or some anger, like, and usually not for themselves, for other people, this sense that, like, this this shouldn't be so hard for people. And so then for study 3, so what does it look like once someone is attached to primary care? I was particularly focused on team-based primary care because that is the direction that we're going in as a country. So here we did a case study and we collected a bunch of different forms of data. So I interviewed 4 clinicians and 6 veterans. We also did a chart review for 28 veterans and a document review of 14 documents that were relevant for the study. And so when we merged all this together, what we found was this particular clinic was a veteran friendly space. And so the veterans felt like it was a safe space for them to be. The second theme is that veterans seem to be a really satisfying group to work with, often because, if they were given a requisition or exercises or whatever, they did them usually. And I guess, at least for the folks that I spoke to, that's not always the case. So they can be a really satisfying group to work with, and working with clinicians who actually take an interest in your experience as a veteran was also something that the veterans really appreciated. Um, and then the third theme here is the paperwork is horrendous, which is probably not surprising to anybody to hear this to hear this particular piece about Veterans Affairs. Um, so the paperwork is horrendous, and really what we're getting at here is that the systemic barriers to providing care for veterans can sometimes be pretty onerous. And so just to give you a sense of what the data looked like here. So for the documents for that first theme there were some publications like newsletters and that sort of thing that highlighted patients in each iteration of this publication, and they would highlight veteran patients, or they might highlight clinicians who had a military connection. Basically, sort of making it known that this is a clinic where veterans' unique needs are considered. And then in that second theme there, this is a quote from a clinician. They tend to have done and seen fairly atypical things and don't always necessarily want to talk about it, but tend to want that acknowledged, which makes sense. Um, and then for that third theme, this is a veteran quote around the barriers related to accessing care. It's the anxiety that, oh my God, I've got to get this done, feeling like I'm bugging him, the physician, again, about, having to fill out all this paperwork. And so the key points here were really that the clinic was a veteran friendly space. Handover from the military system to the civilian system really needs improvement. There was a sense among physicians that there really was no handover. The handover was you get a copy of the Canadian Forces Health System clinic notes for that person. So they felt like there could be something better there. And then again, those systemic barriers that may present challenges for access. So what does it all mean? So this is a quote from the second study. So this is the one where we interviewed folks after they had left service. And this veteran said, if you think of medical care as the hub and spoke network of like a bicycle tire, the center node is the family primary care physician, and all of those spokes are all the different services. It all only works when you have the center hub. So veterans understand how important it is to have primary care. Um, but they aren't always necessarily getting that access. So if you kind of look at this uh, analogy here, if you don't have that center node, the bike is not going anywhere, right? So there's a sense of how important this service is, and therefore a reasonable degree of concern about not being able to access that important service. So the key points I think across all three studies, if I was going to boil it down into 3 points, is that the transition from military to civilian primary care can be challenging. It's not always challenging, um, but when it is, it can be really tough. So that abrupt loss of access to the military health system, if that creates a gap for a person who already has health issues, that can be a very challenging experience for folks. And veteran friendly primary care provision is very important, not just for, getting somebody rostered, but also providing effective care that's going to keep them coming back. And so, on the whole, the experience was described by a lot of veterans using different sort of metaphors and analogies. We talked about the one where folks feel like they're leaving the mothership and they're lost in outer space. Another one that came up a lot was the idea of jumping off a cliff. And so what we want to do here is, build a bridge or at least make the gap small enough that they can jump like this person is here. So the key issues that we can sort of try to do something about that came up in this work were a lack of preparation for health services transition, a gap in access to a primary care provider after release, the provision of veteran friendly care, and of course, we need more research. So, I want to do sort of a quick overview of all those first three key points and what we can do. And then I want to sort of focus a little bit more on um, what clinicians and folks in the civilian healthcare system can do. um, Small things that we can do in our everyday lives. Well, we'll see. I'll let you know, and you can tell me if it fits in your daily life. So that first key issue is lack of preparation for the health system transition. So adding some more education into existing um, supports, like I'm thinking in particular of scan seminars, which are for those who are unaware. Scan seminars are seminars that are meant to prepare military members who have a release coming up, which is everybody. Everybody's going to release eventually. And they're meant to sort of help prepare folks for that transition. And so I think adding a little bit more education around what the civilian system actually looks like so people know what they're getting into. Uh, and also improving handover by making primary care attachment part of that release process, as a sort of a formal step. And then for the gap in access to a primary care provider, uh, this one might be controversial. I have no idea how feasible it is, but this is probably the suggestion that came up the most across all three studies, which was extending access to the military health system after release so that there's not such a sharp cutoff. And then that way you've got a little bit of buffer time to find a primary care provider in the civilian system. Reserving space for newly released veterans on waiting lists for primary care, and addressing some of the barriers to access. So I think one of those will certainly be around the application process for Veterans Affairs service-related injuries. They can be very detailed and onerous, and what I did hear from some clinicians, and again, this is a small sample, but I think it's an important point, which is, if you've already got a full roster, probably more than full, um, it's really hard to then have to fill out forms that are requiring you to do tests that aren't actually necessary to formulate a diagnosis, for example. So some folks did feel that some of those forms were asking for information that wasn't actually needed and didn't change the treatment plan. So when you already have a full load, it's really demoralizing to have to do work that you know is not actually going to change the outcome for the patient in terms of the treatment. Um, it is, of course, going to change the outcome for the patient because hopefully they'll get what they're applying for. But it can be very difficult, I think, and I wonder whether that's something we need to be concerned about in terms of access for primary care providers. Being able to take veterans into their rosters. And then, of course, that veteran friendly primary care. So, I think formulating partnerships between local transition units and primary care clinics is probably a good first step to get the lines of communication open. So at least both parties understand what the challenges are for each other, and then that can help you move forward into finding a way around those. And then also more training in military cultural competence is very important because this is what keeps veterans coming back. This is what sort of helps build trust between you and your veteran patient. Is this cultural competence piece, and I'll talk a little bit more about what that looks like. Um, but before I dive into what we can do, I want to sort of further recognize the very challenging context that we are in when it comes to primary care in Canada. We are in a crisis, and we have been for quite some time, as long as I can remember. um, and we also know that primary care providers have the highest rate of burnout among Canadian physicians, which is not surprising after the pandemic. Um, and so I think that's something that we really need to take into consideration. We can't continue to load more expectation on folks that already have a lot to carry. So I think we have to understand the context that we're in and the challenges that are going to be involved in improving this care for veterans, and again, acknowledging that veterans are one special population of many. And so that's also another important thing to consider is that, you know, our primary care providers have a lot on their plate. And it's important to remember that none of these are complex problems that don't have an easy solution. So, what can you do? If you work in a primary care clinic, whether it's as a clinician or not, advocating for acceptance of recently released CAF veterans at your clinic, if that's possible. Screening new patients for military service and documenting that in the history portion of the chart is very important. I think that's important not just for acknowledgement of military service and having that in the medical background, but it's also really important for future research and being able to collect data on what this looks like in primary care. Seeking out professional development opportunities like this one that will increase your military cultural competence. Again, reaching out to nearby CAF bases to learn more about what this process looks like and what the need is in your community. And also consider participating in research regarding military populations, whether you're connected to the military, a member yourself, a veteran, clinician. Um, Keep your eye out for studies. We're always looking for participants. And, if you can swing it and you're keen, by all means, reach out. So I think the most important piece to focus on here in terms of what to take away here is this idea of military cultural competence. I think this is going to be the key or one of the key elements in improving quality of care for veterans and improving access. And so there's sort of three elements to this that are kind of, these are this is the way that I remember these elements. So it's care, know, do. So caring about is basically, the acknowledgement on a cognitive and emotional level that veterans have had unique experiences, and that their health needs may be different from other folks as a result of that. N- know or knowledge is the specific knowledge about the cultural group, which in this case would be military veterans. So you can do that. You can learn more about the military just by asking questions a lot of the time, right? Asking folks to tell you what they did in the military, what service element were they in, um, did they have deployments? What did that look like? That kind of thing. And then skills, this is that do part of care, no, do. This is where you actually change what you're doing or how you're interacting on the basis of the caring and knowing. So this could be an example of this could be if you have a veteran patient who's freshly released, giving them a little bit of a crash course around what they can expect in the civilian system. So things like wait times are probably going to be a little longer than you're used to. You may not be able to find a primary care provider as easily as you had hoped. So some of these things that, just advising people of what they can expect. And so I'm not going to spend too much time on this slide, but I just wanted to include it as sort of a list of resources if you want to learn a little more about military and veteran cultural competence, and in particular, how it relates to healthcare service and quality. And of course, some directions for future research. This is really very new. The interest in the healthcare transition piece of MCT is certainly increasing, but it's still very new. So we really need to examine sort of the effectiveness of the services and supports that are already available, and get a better sense of where the gaps are, and what are some low hanging fruit that we can put into action. Also, investigating the magnitude of risk factors associated with gaps in access. And this work is actually already underway and completed and under review at a journal. I think it's military behavioral health, so hopefully we'll get it out real soon. Um, Also, further examination of primary care provision for veterans in the civilian world, just in general, because this is one study, and of course, you know, one sample. So we definitely need more to have a better understanding. A greater focus on intersectionality and around how some of the different identity factors can influence what the experience looks like. And I think this isn't necessarily just around identity factors, but also military factors. So, for example, what influence does rank have? What influence does service element have? Those sorts of things. And then refinement and validation of the uh, military to civilian transition theory and framework. Theories and frameworks inform policy. So, Veterans Affairs does have um, a well-being framework for veterans. But to my knowledge, it's never been validated. So I think putting a little bit more uh, emphasis on our theories and frameworks that we have to kind of get something that's a little bit more robust would be helpful. And just to give you an idea, some of this stuff is already in the works. So I was involved in a project with Dr. Lena Tansito at University of Toronto, funded by the Veteran and Family Wellbeing Fund and Callian, where we created some reference guides for clinicians who are serving veterans and their families. And we are also conducting some work around what this looks like specifically for veterans with chronic pain. So, looking to create a similar resource guide, but with a little bit more evidence base to it, and a little bit more fleshed out than the Callian one. So, in terms of takeaway messages, the transition from military to civilian health system has often been overlooked, um, especially if you're already healthy, right? This might fall by the wayside for sure. The health service transition can be challenging, especially if you've got ongoing health issues that need regular follow up. Military cultural competence is an essential element of access and quality because if you don't have that trust, the person's not going to come back, and that takes away access, right? Even though you're available, it doesn't mean you're accessible. Um, and then primary care providers, like they are for everybody, are vitally important in supporting veterans in the transition to civilian life. So it's really important that we make sure or do the best that we can to make sure that we limit those gaps and make sure that we have as much continuity for veterans as is possible um, as they leave service. So that is the end. My contact information is here if anybody would like to reach out. You can also look me up on LinkedIn. Um, some references for you, but I think I actually managed to finish with enough time for some questions. So thank you very much for being here today and for your interest in this, and I look forward to hearing what you have to say.
Thank you so much, Ashley, for sharing that. What an incredible body of work, and I like the way you told the storyline of how that work progressed over time.
Thank you.
Open to time for a couple of questions.
Oh, Catherine, you look like you're in a palace or something.
Sorry, it's the crazy lighting. I am in a library, but I
Oh,
just
at
want to say
Queen's?
I'm actually overseas right now, but I just
Okay.
wanted to say congratulations, Ashley. It's like really impressive to see everything come together and
Thank
how
you.
it feeds into this important common message, and really more importantly highlights this is just really the beginning, of this work, thinking about transitions. And you started it before there was a heavy focus, and it's landed in such a great opportunity in a time right now when we think of the crisis. So just want to say congratulations and nice to
Oh,
see you.
yes, thank you. And thank you for all your support in getting me here. So, for anyone who doesn't know, Catherine was one of my supervisors. And Jordan, you were an examiner at some point. So, thank you as well.
Yeah, my pleasure. My one question, if I can sneak one in, I know we're approaching the top of the hour, and we do often see people trickle off as we approach the end. But the idea of one of the future directions for research that you identified was evaluating services available and identifying gaps. And that idea of identifying gaps seems, really important, but also really big. Any first steps that, health services community that interested in embarking on that would take, like with the, how would we start on that research path?
Um, so I mean, I have some ideas that might be fairly specific, but I think one is that taking data from that longitudinal study, because there's also a piece in there around supports and services. Now, you would have the same issue around depth and breadth, or sorry, depth and thickness, of course. Um, but that's data that's already there that we could do something with. And then that might also give us a sense of which questions we need to ask when we do a deeper dive into this. I think the other thing that makes a lot of sense to me to do would be an environmental scan of some sort to actually look at, what are the resources available and what do they actually cover and how far away are we from, what folks would like to see in terms of more preparation and support.
Yeah, thanks for that. Yeah, it feels like also as models change and evolve in primary care, health administrative data where we can identify, some military indicators of saying, I know there's been work already around access and how does access look similar or different in
Yeah.
veteran populations, but as things evolve and change, it would be interesting to also, monitor what models are veterans accessing care through, and are there any gaps, that can be identified that way too? Anyway, just an idea that comes to mind.
Yeah, well, some of that work that Alison Mahar did, that was done through ICES. And they do actually, Ontario does have an indicator for veterans. It also includes RCMP veterans. Although I'm not sure how much of the sample includes RCMP. It is mostly military veterans. So we do have that, and I'm not sure if that exists for other provinces.
Yeah.
But that'll tell us about utilization, right? Because that's how we know that veterans also use primary care more often than the general population. So utilization is one part of the piece when we talk about access as a whole. But yeah, we definitely need more indicators like that for sure.
Well, thank you, Ashley. We really appreciate you, devoting your lunch hour to spending it with us here at HSPRI. It was really great to hear about your work, and I'm sure everybody else that would join us appreciate it as well. Look forward to staying in touch. Thanks
Awesome.
again.
Well, thank you again, everyone, for being here. And like I said, happy to chat if anyone wants to reach out with more questions.